Right, thanks to Mark for the invitation to speak to you all today. So the title has changed since the original programme was sent out on Mark's request to incorporate more than just a little bit more than contact mixing behaviour, and to try and kind of consider, or at least bring up, some of the other important behaviours that we might think are important for influenza transmission. And here I've got kind of to model and potentially understand, although they're kind of the same things, but it does depend on what your purpose is, whether you know, to be able to predict for public health purposes, you need to really understand first. Okay. And so what sort of behaviours are we potentially interested in? So we could be interested in things that can affect individuals' risk of exposure or their transmission to others, okay, or behaviours that may augment or potentially affect surveillance, okay. And so things that we're kind of thinking about are behaviours like social mixing patterns and how you interact with the community, for how you may be infected or you may infect others, sort of the epidemiological life history parameters, so how likely you are to seek care and to receive treatment if it's available, how likely you are to just take time off work and have man flu at home, or whether you're going to actually increase your respond to public health messages and increase your hygiene behaviour, or whether you're even going to get vaccinated. And so these are all kind of important factors that we as modellers would like to know much more about. But unfortunately, you know, for us to be able to incorporate it into models, we need to understand them, and somebody needs to measure them. Okay. And of course, they're not necessarily static things. So all of these things can be subject to very large dynamical changes as an epidemic unfolds, particularly a pandemic, as we saw in 2009. And so there's various factors that may be driving those behaviours. And here we could really do with some key input from sociologists and psychologists about what factors they may be. And here I've kind of listed a few, sort of what your personal experience is, what messages you're getting from the national media and what your peers are potentially doing on social media, what the public health response is going to be in terms of giving messages to you, and then kind of integrating all of those, sort of how this plays out in your own social network and kind of normative behaviours and how they may influence you or not. Okay. So I can't believe I'm giving the first equation of the talk, but anyway, this is the last as well. So I think it's worth reminding ourselves that even the simplest epidemic models incorporate behaviour. You know, the epidemics are driven by human behaviour. So the parameters that most of you here will be familiar with beta and gamma here, describing the transmission rate and the recovery rate, are driven by behaviour. You know, so how much people mix is going to drive transmission rates, how infectious they are, what they do to limit that infection, if they're using hygiene, is going to affect that, and how likely they are to seek care or to rest and withdraw from society, and so on, can affect how they recover. So, even the simplest models incorporate it, and we'd love to incorporate much more detailed information as and when it's necessary. So I'm first of all going to talk about contact patterns and kind of social mixing behaviour. And contact, really, certainly for influenza, seems to be fundamental, or is thought to be fundamental, in driving the spread of influenza. You need to meet people, or at least co-locate with them, to give them your virus. Okay, and so this could be a social encounter, proximity to them, sharing objects, so fomite transmission, or just even being in the same room, or going in the same room after somebody's been in it. They can all potentially be important, and to some extent we still don't really know how flu transmits between these different mechanisms, or let alone how that differs in different settings. But I mean, there's some important work going on now that I won't cover here. There's kind of trying to model this, and people are looking at that, particularly from the genetic sequence aspect for household studies. It's proving quite illuminating. And of course, a lot of public health interventions depend on there being some sort of, that contact makes sense in terms of flu transmission. So things like, otherwise contact tracing wouldn't work, or school closures or quarantine, none of those would really work. So there has to be some sort of relationship. So that's the justification for focusing in on it. And of course, you know, if we think about our contact patterns, you know, we don't behave like these simple models. You know, the simple models assume that everybody interacts with everybody else, a little bit like the we're all balls in a big ball pit, and there's this metaphysical child juggling us all together in a random way. You know, that clearly doesn't happen at some scales. The so-called random mixing, you know, and likewise, not everybody here met everybody in London today, a little bit. You know, we met kind of closed, kind of finite-sized social networks. So, in reality, individuals only have a few contacts with other individuals, and groups of individuals tend to preferentially mix with other groups, potentially the same group or other ones. So there's some ways we can start moving away from a random assumption and start to make sensible models. Okay. So why do we need to know this contact rate? So estimating transmission rate with a non-structured, simple transmission model is relatively easy. But as soon as we have a more complicated model, where we have, say, two different groups of individuals, high-risk and low-risk individuals, the transmission term, instead of becoming a single term, becomes a matrix, and we need to try and understand the numbers in every cell of that matrix, okay? And in particular, when we only have kind of infection rates in different groups to go on, it's very hard to determine how to pattern this matrix, okay? And so that kind of led to a push, notably by John Edmonds here, to try and measure these contact patterns between different groups that we're considering, both in public health terms and in terms of the modelling. Okay, but how do we go about measuring contact patterns? So here I've kind of listed four main ways that you can do it. You could try direct observation, so kind of borrowing heavily from animal behaviour studies. You can actually sit down and watch people if they don't change their behaviour too much. It's intensive, to say the least. We've done it in US school using video in kids and looking at how often they touch each other, and it's generally a big pain in the arse. And you can't really do very kind of mass sampling at any one time. So it has its uses, and in some ways it's potentially the gold standard, but it's got its limits of how many people you can actually study at one time. In contrast, getting people to tell you about their day and asking them about how many contacts they made and who they were, you can do in a very widespread way, representative of the population in a very low-tech way, just pen and paper and questionnaire. An alternative way is proximity sensors, which is quite a few groups around the world are now using these to basically put these sensors on people, and it will automatically record the interactions with other people who are wearing the sensors. Obviously, they're kind of measuring different things, and they both have their own limitations. And then finally, you could potentially infer from secondary data, which I'm not going to talk about. I'm just going to mention the contact diaries and the proximity sensors. Okay, so one of the key studies that has come out and has been, really influential in promoting other studies and in its usage in public health modelling is the Polymod study. Just over 7,000 individuals across 8 countries, European countries, and it's questionnaire-based design focusing on age mixing patterns. And they found very strong assortativity by age. So we get this very strong diagonal in this kind of contact matrix where similar age people tend to have most contact with the same age groups. So and the other important thing that came out was that children had the highest contact with other children, and then outside of kind of school environments or social environments, they'd also have contact with their parents occasionally, even if they get locked in a different room. And so you get this very kind of almost iconic shape of this kind of pattern of age mixing. And when we put this into models, we get sensible things coming out. So this is a model output from the Polymod original paper showing the sort of the incidence in different age groups using the country-specific mixing matrix, and you make some assumptions about how everybody is susceptible. And you get this sort of differential infection rates in different age groups based on this mixing pattern. Okay. So another key study that was done a little bit before Polymod came out was by Jacco Wallinger, and he was looking at some slightly different data in the Netherlands, which was kind of estimates of how much contact between different age groups based on a sociological survey, and then comparing that to infection rates in known age groups based on a serological study. And one interesting thing that he found was by models that incorporated this contact information were significantly improved in terms of explaining the pattern of immunity seen in the population for mumps, measles, and in particular influenza. Okay. So this is kind of circumstantial population, ecological level evidence that incorporating these, it's important to know this sort of contact information. Okay, and then the current state of the art, if I can call it that Mark Baglan has been responsible for, as well as others, is to incorporate this sort of this polymod mixing information into dynamical models of seasonal influenza transmission for the explicit purpose of predicting what effect a new vaccination strategy would have. So this is the sort of model where they take the contact mixing information as well as other known information. They fit it to historic seasonal flu incidence to estimate other important parameters such as age group specific susceptibility and transmission rates, and then use that to predict what's the effect of vaccinating school-aged children on the whole population's incidence, and then see whether it's cost effective. Okay, and that, this is the model that's kind of changed policy. So that is the current state of the art. But even that model is relatively, in terms of what modelers can do and do, is relatively simple. No offence, Mark. And there's an awful lot of wealth of information about how people interact that potentially could be included in these models. Perhaps we don't have this sort of representative information to incorporate it, or nobody's bothered to see whether we can get further improvements in our prediction of infection. Okay, and so one such thing would be how many people you actually meet, accounting for the sort of the individual level or between individual level heterogeneity in population. So this is a similar study to the Polymod study that we conducted in the UK. We had about 5,000 participants, including two strikingly contrasting famous names down at the bottom. And we were very much focused on the network structure because that was our background, rather than the age mixing patterns. And we deliberately made the questionnaire easy to report a lot of contacts, and so we got this kind of very clean degree distribution where it almost has power law properties, and some people were reporting a very large number of contacts a day, and others were reporting much less. And we also focused on sort of the clustering, so we would ask individuals, the ego, about their contacts and the relationship between their contacts, so we get some idea of this, how much interaction is there between their contacts and this clustering coefficient. And we found some potentially useful, certainly intriguing information about how clustering changes at different distances from home. So the further away from home you are, the clustering increases, which kind of makes sense. I've come all the way down from Lancaster, and everybody I meet today is probably also going to talk to each other. Okay. So it kind of makes sense in it sociologically. But it's also potentially important for transmission. Okay, and there's a huge amount of variety between individuals in this sort of information. So that's just a snapshot of 50 odd. Okay. So it would be nice to incorporate that information if it's important. Another way to measure contacts is using proximity sensors, and this is best applied to very small kind of closed or semi-closed populations where you can kind of saturate the community with these sensors and record most of the information. And so you get very detailed network information across time in particular. So far this has only really been done in school and hospital-based settings. It'd be nice to see more studies doing it in communities. And one of the key things that these studies find is that there's very many brief encounters, so lots of short kind of ships that passing very quickly, particularly when classes move out of classrooms and kind of go to another classroom. And it's important, certainly for understanding the transmission dynamics, that you incorporate this information about individuals rather than aggregating over time. A recent paper by Damon Toth and the Utah guys who have been doing similar studies in US schools show that that's the case. But you can still recover sensible information like sort of how much assortative mixing within schools, as we've done here in Pittsburgh, from this sort of information, from this technique. Okay. And so, you know, it kind of hints at that it's not enough just to measure contact patterns once for an individual. You need to consider how they change over time. And one, at sort of the large scale, that's really important. Here we've got the estimates of the UK, or in the UK, the 2009 influenza pandemic from various sources, and you can see we've got two main peaks, and it corresponds very closely with the school holiday. Okay, the start of the school holiday in England essentially shut down the epidemic during the summer. Okay, and then it didn't start again until the schools went back. Okay, so it's pretty much clear evidence that changes in contact patterns really matter. Okay, and one of the nice study that again John and Ken Eames were kind of involved with was during the pandemic they asked some people were recruited from when they were collecting their antivirals to fill out a contact diary when they were ill and then fill it out again a few weeks later when they were not ill. And then so we've got, for individuals, we've got some contrasting information about how their behaviour changes when they're healthy compared to when they're ill. Okay, and so they got this information and they incorporated it into models, and they found that it was useful to have it in the models, and that they could also estimate other key epidemiological features of influenza, such as how much transmission must have been happening if people were asymptomatic, and so on. So it's a really good example of incorporating that dynamic change into models. Okay, and then the last thing I'd like to talk to you about contact diaries is again taking this how much variation is there in people's day-to-day behaviour. We have a study in China called Fluscape, which is a cohort study with about 2,000 people in it. And we've now got 3 rounds of field work, so we have 3 annual surveys from people of their daily contacts. And so we've been able, with Justin Lester, we've been able to analyse how much variation is, in terms of the number of people that you meet, is within you, and how much this variation is between people. And we see the majority is actually within person variation, okay, just about, okay, and that changes in different settings and certainly changes by different age groups. So once you start getting old, you start getting more regular days, slow decline into boredom. But of course it's really important to know this sort of thing when you, depending on how you simulate your epidemic, whether you've got whether you consider that it is Groundhog Day and you have the same number of contacts day in, day out, or whether you're going to change them and you draw from a distribution every time, really makes a huge difference into the transmission dynamics. Okay, so it's important to know these things. And then one final kind of thing is that potentially it's not enough to know about contacts of the individuals, it's also about how they integrate into the community. So a Hong Kong study that On Kwok, Adam Kacharski and Stephen Riley have been looking at, it has kind of taken the contact information and the serological infection incidence of infection in a cohort in Hong Kong, and really kind of trying to dig into what's the contact information that we need that best explains our infection rates. And one of the unintuitive things that comes out of it, I think, is that individual level contact behaviour, knowing about that, isn't sufficient in and of itself to explain who got infected. You also need to know more about the average behaviour of their age group. Okay, and in particular, one of the important features is this. So as we age, we have different numbers of contacts on average, and as you take the shift from going from basically school age to adulthood, your contacts drop, unfortunately, no matter how much you try to recover them. And so that's a key feature in explaining the infection dynamics, and also the sort of the slight rise again when you reach parenthood age. That's also important, probably because you're having contact with children. So it's a complicated picture, and it's important, I think, to try and understand what is the relevant information to incorporate into models to make them better. Okay. So that's contact behaviour. Some other behaviours that we might really want to know about are things like how people are responding to messages, how people are care-seeking, whether they're taking time off work and absenteeism, and just generally, you know, that there's things out there like Facebook and Twitter, the social media, which are amenable to mass observation, okay, in almost real time, okay. And there's a lot of interest in using that information to try and understand what's happening for surveillance purposes, but also for modelling. And increasingly there's better coverage in all age groups for it, except perhaps children. But one thing I would really caution about is that the biases and limitations of this are not well understood. Yes, we've got a lot of data, it's classic big data, but it's potentially quite poor data. And so does the size of it overcome the limitations of it? And one particular failure, you know, something like internet search terms and the Google flu, you may be familiar with it, you know, that failed completely during the pandemic because people's internet search behaviour was so influenced by media that they were, you know, if you just relied on who was looking for flu as a measure of incidence, you were going to get it completely wrong. Okay. And just one final example of an alternative data stream which might have its uses in both in modelling and surveillance is retail sales, over-the-counter sales of you know, flu and cold remedies. So we got a whole load of data from a major UK supermarket, which was spatially down to all the store levels, and we looked at how it related to both kind of media interest and search terms during the pandemic, and also the estimates of the local incidents as well. And you can see basically that for some things it was pretty much flat. I think that's for I can't even see. Oh yeah, tissues. That's right. There's a lot of public messaging about, you know, catch it, bin it, kill it. So we were interested. Did tissue sales go up? Not at all. Did antiviral tissues and products actually went up a little bit? And you notice they go up most sharply at the very start of the pandemic, when there was almost no cases in the UK. But the biggest rises we saw were actually for sales of thermometers. So people were responding to the idea that they had to take their own temperature, okay, before they could go and collect their antivirals. You know, did you have a fever? How do I know I've got a fever? I've got to buy a thermometer. So people were responding to public health messages, and you know, and one of the big challenges is how do we incorporate that sort of information into our models to make them better. Okay, so just to summarise then, I think it's important that we do try to incorporate this behavioural information where we can and where it actually improves. And it just generally, you know, a general rule of thumb is that if you do incorporate it, if it's sensible, then it does tend to improve the models. Okay. At the moment, the models that are actually driving policy forward only use aggregate measures of contact. So we're summarising within different age groups and so on. So you know, it's an open question as to whether we need more information incorporated into those models to make them better. Slowly, you know, the other feature is that, you know, it's a dynamic world out there. Perhaps we need to incorporate those sudden changes. And we're starting to see more models now that actually incorporate changes that are sensible. But again, it's very difficult to understand what those magnitude of those would be unless you've measured it somewhere else first. And then finally, as I say, other behaviours are important too, potentially, but they're very difficult to measure unless you go out and measure them. One study that I haven't mentioned in this is the flu survey study, and I deleted the email from them again this morning. Sorry, John. But you know, that's a great example of a community study, a community-based study that is trying to measure both incidence but also people's behaviour around flu and what they think about flu and how they're responding to it. And those sort of community studies both for that and also for perceptions, are going to be really important, certainly come the next pandemic. You know, we need to have them embedded now to be able to use them for modelling. And so I kind of question the reliance on this big data. You know, there's a lot of big data is definitely sexy, but what is its utility, really? And how do we incorporate information or behaviours that we see in that into models? Okay. And then finally, I'd just like to thank these wonderful people here for some of the work that I've shown you that I've been involved in, and the funders as well. And you guys for listening. Thank you. Any questions?
So thank you for your talk. So the contact pattern, or the change of contact pattern, I think it will be very important to predict the disease incidence. And you also give the example that certain factor will also affect the dynamic of the contact pattern.
Yeah.
So beside the person who are infected, for other person, I'm thinking they will also be affected by some, like their colleagues or their friends, if there's a disease incident increase or decrease. So I'm wondering whether it's possible in the future we can have some tools or some method that we can real-time monitor the change of the contact, maybe based on some social media or the mobile phone owned by the different age group.
So that would be wonderful, wouldn't it? If we could have put an app on everybody's phone that told us if they, if it monitored where they were going, and you can suddenly see them not going to work. You could probably pick that out from somebody's mobile phone, or social media saying, I have to care for my child today, or my mother, or whatever. Or my husband, yet again. I think whether we'll be able to do that, I don't know. And I think one challenge of incorporating that, it's very easy for me to say, yes, let's try and put extra information into the models and see if it improves the fit. I mean, unless we have, I guess, more detailed incidence data, we may struggle to see any improvement beyond the sort of aggregate measures that we use now. So one thing I kind of suggest to everybody here is that to think about is whether we need to have kind of improved surveillance in a way to get more detailed information about who's getting infected, so that we could see whether this extra information is actually going to be beneficial. It's not necessarily an answer to your question, more of a rant, but yeah, I don't know. Does anyone want to comment on that? John looks like he does.
We did measure behaviour during the flu pandemic through flu survey,
yeah.
And it did change, but it just changed because of school holidays, which, so we didn't measure any change because of levels of concern. But the other thing I wanted to say is I wondered whether, I think the Google flu and similar kind of exercises, including the one that you did with the
retail sales.
The retail sales, which is really interesting. But I wonder whether that really measures more accurately. I don't think Google Flu works very terribly well, but I think it might measure more accurately levels of concern.
Yeah.
So it really reflects levels of concern more than it does the epidemiology.
Yeah, and how that translates into transmission-related behaviour.
Yeah,
is a big unknown.
That's not really known, but it's measuring something which is potentially important.
Yeah.
I think in the 2009 pandemic, epidemiologically, it wasn't terribly important at all. But you couldn't rule out the fact that in another epidemic, it would be important. So it's measuring some level of concern, and if that affects behaviour, whether that's affecting behaviour about going to the doctors. In fact, it did affect that. It probably did affect going to the physician-type behaviour, but whether it affected epidemiologically transmission, I don't think it did at all. I mean, that's my hunch. We haven't really got any data on it, but I think that's the next thing to do, would be to try and work out how levels of concern
translate into
into actual action.
incidents. Yeah, I agree.
So maybe it's time now for next speaker, Anne Presanis.